Hello and welcome to Healthy Seminars. I'm your moderator, Lauren Brown, and today we have two in the month of June with Dr. Mark Ratner. Our first topic is going to be on cannabinoid therapeutics from chronic pain to COVID-19, and then you should know that he's going to be doing another one on June 16th on micronutrients for viral infections, separating fact from fiction during COVID-19. But before I move into Dr. Mark presenting, I just want to do a little bit of housekeeping with you guys. I will let you know that this is for educational purposes only. This is not medical information. This should not be interpreted as medical information, and nothing in this lecture do we endorse. This is for educational purposes only. All right, we can take that down, and Mark, you can start sharing your PowerPoint. I want to share that I met Dr. Ratner a few years back. He was a presenter at the Integrated Fertility Symposium, so I know this is going to be an excellent presentation. And I met the group Theralogix as well. Thank you to Theralogix for sponsoring this webinar. And I met the group, and they've been at the Integrated Fertility Symposium for many years. And I was introduced to them through one of their products for polycystic ovarian syndrome that contains minoxidil and stuff. And I just started learning more and more about their products. And we were having a discussion about COVID, et cetera. And Mark had a lot to say on this and evidence-based. So we thought it'd be a great opportunity to hear about this. And hence, this is why we're having this presentation. Just a brief introduction to Dr. Mark Ratner that I think is really relevant here is he is a practicing physician well over 30 years, and his undergraduate and master's studies was in nutrition at Cornell University. So he's an MD, and he's also got some good nutritional background, which is why he's a really good physician to talk about this topic on cannabinoids and the one he's doing on the 16th on all these macronutrients that have to support them for viral infections. So I thought it would be great to have a medical doctor that actually has nutritional background, because most physicians historically got very little nutritional background, but Mark has spent a lot of energy and time to get knowledgeable in that area. So during the webinar, if you have any questions, post them in the chat room. We're going to moderate those for Dr. Ratner at the end of this webinar, and you'll have a chance to raise your hand digitally if you want to ask those questions verbally as well. So Mark, without any further ado, I'm going to mute myself and I'm going to sit back and learn.
Okay. Thank you, Lauren. You guys can hear me, right? It's all good? All right, great. So as Lauren said, I'm a physician. I'm also the chief science officer for Theralogix. And today what we're going to do is I'm going to explore some ways that we can use cannabinoids to treat several related conditions. Chronic inflammatory pain, neuropathic pain, viral infection potentially, even depression. And you might say, well, how are those related conditions? And the answer is that they all really interact with the immune system. And so I'm going to start off with a quick review of what we call a human endocannabinoid system. Now, for those of you living where cannabis is legal, you may be familiar with this. So I won't spend too much time on it, but I'm going to initially focus on how the human endocannabinoid system impacts immune response, inflammation, and pain. Next, we're going to talk about CBD, its mechanism of action, and then what the published studies tell us about efficacy and safety. Next, I'm going to introduce you to a compound which is called PEA, Palmitoylethanolamide, which is unique in that it is an endogenous and exogenous cannabinoid. And we'll talk about that. And finally, I'm going to introduce you to our company's product, our company's PEA product, which is called Cannabrex. So when most of us think about cannabinoid therapeutics, we think about cannabis. And the potential medical benefits of cannabis have really been known for thousands of years. But it wasn't until about 30 years ago that we began to understand how the exogenous plant cannabinoids in cannabis actually affect us. And to also understand that the human body actually makes its own endogenous cannabinoids. Most of the work that was done in this realm over the past, say, 60 years was done by this very sweet-looking grandfather. He's an Israeli biochemist whose name is Raphael Mechoulam. And he actually led the work with others that led to the discovery of the human endocannabinoid system. So what is it? What is the endocannabinoid system? It is a system within our body of receptors and signaling molecules. And the history really started back about 55 years ago. Mechoulam was the guy in Israel who first identified CBD and THC, which everybody knows are the two primary bioactive components of cannabis. But Mechoulam said to himself, well, why do these two compounds have such an impact on our bodies? We must have receptors in our body that these compounds are actually binding to and activating. And so it took about 25 years, but then in the early 1990s, they finally discovered two of the first two cannabinoid receptors, which were called CB1 and CB2. Then the question became, though, why should we have these receptors for compounds that are only found in this one particular plant? And so Mechoulam and his coworkers basically said, we must make our own cannabinoids. We must make our own signaling molecules in our bodies that are designed to bind to these receptors. And in fact, very shortly thereafter, they discovered two of them. The first one, the first endogenous cannabinoid ligand, and ligand simply means a signaling molecule, was identified, and Mechoulam named it anandamide. Ananda is the Sanskrit word for bliss. And so he called this the bliss molecule. Biochemically, it is arachidonyl-ethanolamide, which means it's a fatty acid amide derived from arachidonic acid. And so typically these days, you'll see it abbreviated as AEA. And then just a couple of years later, the second endogenous cannabinoid ligand was identified, and it's called 2-AG. And again, it's derived from arachidonic acid, which is a fatty acid. And so it's 2-AG is the second of these main cannabinoid signaling molecules that we make in our tissues. So this system, this endocannabinoid system is present in all vertebrates. It's estimated that it evolved about 500 million years ago. The purpose of the endocannabinoid system is, at a high level, it maintains bodily homeostasis. And what that means is this: it's designed to return us to a baseline physiologic state after our body reacts to a change in the environment. And we're going to show you, I'll show you what that means in a little bit more detail in a minute. But it primarily functions, this human endocannabinoid system, in the central nervous system and in the immune system. It's involved in pain, in memory, in mood, appetite, stress, sleep, immune and reproductive function, metabolism. It's really got roles in almost every major function in the body. So this endocannabinoid system is really comprised of three components. We've talked about two of them already. The first are these two main receptors, CB1 and CB2. And now we've got these two main signaling molecules or ligands, AEA, which Mechoulam called anandamide, the bliss molecule, and 2-AG. And then we've got regulatory enzymes. We've got enzymes that produce the signaling molecules, and then we've got enzymes that break down the signaling molecules. There's also two additional receptors that we should know about. And actually, before we move on to those two other receptors, FAAH, the breakdown enzyme for AEA. Keep that in mind because we're going to come back to that a little bit later in the talk. It's a really exciting compound that's got some amazing potential for us to work with, and we'll talk about that a little later. So we have two other receptors that I want you guys to pay attention to. One is called PPAP Alpha, and the other one is called TRPV1. Now, we call these cannabinoid-like receptors because they weren't initially discovered as like CB1 and CB2, but it turns out that these two receptors are also being bound by the same cannabinoid signaling molecules. So we've got these four receptors. And if we're going to talk about how the endocannabinoid system interacts with inflammation and with pain, these are the receptors that we should really focus on. So we've got CB1, we've got CB2, we've got PPAR Alpha, and we've got TRPV1. Okay, what do they do? So I'll spend about a minute or two on each of these. CB1 receptors are on the presynaptic neurons in the central nervous system. So what does that mean? It means that they are there to reduce neurotransmitter release. And here's a diagram which it's going to look a little bit daunting. Don't worry, this is not on the midterm. And let me take you through this and show you kind of how it works. So this big blue thing at the top here, that's the presynaptic neuron. You know, when two nerves meet, we call that a synapse, and the space between them is the synaptic space. So the presynaptic nerve signal comes down that nerve, and then the goal is to transmit that signal across the synapse to the postsynaptic nerve. And the way that that signal gets transmitted is through the release of neurotransmitters. And we see that right here, where these little green dots get released, they diffuse across the neurotransmitter. I'm sorry, they are neurotransmitters which diffuse across the synapse, and they trigger the signal to continue down the postsynaptic neuron. But we don't want that transmitter to just keep getting released and released and released. And so what happens when the neurotransmitter diffuses across the synapse and it binds to the postsynaptic neuron is the postsynaptic neuron then releases anandamide and 2-AG, those two main endocannabinoid signaling molecules, and they diffuse backwards. They go backwards across the synapse in what we call retrograde signaling. And this is the only place in the entire nervous system where we see this backward signaling from postsynaptic neuron to presynaptic neuron. 2-AG and anandamide, they go backwards and they bind to the CB1 receptor, which then shuts down any further neurotransmitter release. So this is essentially a negative feedback mechanism. It's a homeostatic mechanism that essentially says to that presynaptic nerve, return to baseline. And this is what the endocannabinoid system does, not only in the nervous system, but as we'll see in a minute, in the immune system as well. It's designed to return us to baseline. So it turns out, though, that the CB1 receptors in the central nervous system are really not directly involved in reducing pain or inflammation. The CB2 receptors, on the other hand, are. Now, they are found in the immune system. They're found on mostly white blood cells, in the thymus, in lymph nodes. And the purpose of the CB2 receptor is to moderate immune response. So when the immune system gets activated, CB2 receptors basically serve as a natural anti-inflammatory because they trigger the immune system to downregulate. And so essentially, this serves as a negative feedback loop for the immune system and the immune reaction, and they serve as a natural anti-inflammatory. PPAR alpha, this is the third one to think about. These receptors are found on a very specific type of immune cell, which is called a mast cell. This is a special type of white blood cell. Mast cells contain a ton of cytokines, and we've all been hearing a lot about cytokines lately because of COVID. So what happens if you activate the PPAR alpha receptor on these mast cells, they downregulate the release of cytokines. And so the interleukins, the interferons, the tumor necrosis factors that are released by mast cells, when you activate the PPAR alpha receptor on the mast cell, it downregulates their release. And so essentially it produces a natural anti-inflammatory effect, much like CB2. The last receptor we call TRPV1. And this is a receptor that's found on the surface of pain neurons. And when you trigger that receptor, it typically helps transmit pain down that neuron. It transmits the signal of pain down that neuron. When they were first discovered, these receptors were called the capsaicin receptor. Capsaicin is the chemical that's in hot pepper that, makes your mouth burn. And what we know about capsaicin is that once you put capsaicin on this receptor, after a short period of time, the receptor becomes desensitized, which is why there are ways that capsaicin is used to reduce pain. So the old icy hot, the patches, the creams that you can put on painful areas of the body make use of these TRPV1 receptors. But it turns out that certain cannabinoids will directly desensitize the TRPV1 receptor and reduce pain sensation. So we've got these 4 receptors, CB1, which are in the central nervous system, but they don't really directly involve pain or inflammation, CB2, which are on immune cells, PPAR Alpha, which are on a special immune cell called a mast cell, and finally the TRPV1 receptors, which are on pain neurons. Okay, so we go back now to those 2 endocannabinoid signaling molecules, the 2 molecules that Meshulam discovered, AEA, which is anandamide, and 2AG. How do those signaling molecules interact with those receptors? Well, AEA, turns out, strongly activates CB1. I guess that's why he called it the bliss molecule. But only weakly activates CB2, PPAR alpha, and TRPV1. 2AG, on the other hand, strongly activates CB1, CB2, and TRPV1, and weakly activates PPAR alpha. So now, what about the big exogenous cannabinoid, the cannabinoid that everybody says is good for so many different conditions, CBD? How does CBD interact with these 4 receptors? Well, it turns out that CBD binds and desensitizes TRPV1. And that is really primarily how it affects pain sensation. It also weakly binds to PPAR alpha, so it has a weak anti-inflammatory effect. But the other thing that CBD does is it competes for the breakdown enzymes of 2AG and AEA. And so by competing for that breakdown, you increase tissue levels. When you take CBD in, you're increasing the endocannabinoid tissue levels of AEA and 2AG. And so by increasing those, you're going to indirectly stimulate CB1 and CB2. So that's the basic mechanism of action for CBD in terms of pain and inflammation. So let's turn for a moment now to CBD. If that's the mechanism of action, what do we know about its efficacy? So it turns out that the strongest evidence is in epilepsy, and in fact, pediatric epilepsy. There's a condition called Dravet syndrome, which is it's sort of resistant to treatment with typical anti-epileptics. And 2 years ago, GW Pharma, which is a British pharmaceutical company, was given drug approval here in the United States for a form of CBD, which they have a brand name called Epidiolex. And the data on that is pretty good. What about anxiety? Well, there's actually only a single published study in subjects who have simple social anxiety, but there are several studies looking at the ability of CBD to reduce anxiety for using an artificial stressor, public speaking stress. And it turns out that those studies, compared to placebo, CBD does show a significant reduction in anxiety, but using very high doses of CBD in the range of anywhere from 150 to 900 milligrams, which if you've had any experience with patients in CBD, you know that that's way more than typical commercial products are going to provide. The impact on anxiety isn't that surprising because there's evidence that CBD actually does activate the 5-HT1A serotonin receptor. So that would explain why it calms people down. I mean, anecdotally, you'll hear patients tell you that all the time, that CBD kind of helps them sleep better, or it just kind of relaxes them. There's some amazing data on CBD and schizophrenia. actually multiple randomized trials. And in 2012, there was a trial against amisulpride, which is an atypical antipsychotic. And basically, CBD was just as good, although the dose was 800 milligrams daily. So what about CBD in pain and inflammation? Well, it turns out that almost all the studies are in animal pain and inflammation models. There are really no human studies yet published with pure CBD using either oral or inhalation route of administration. There is one human randomized controlled trial using CBD cream in patients who have TMJ pain, temporomandibular joint pain. And it was published just about 7-8 months ago. It was published in Europe, and they basically took 60 patients who had TMJ pain, and they randomized them to either using CBD cream, and they actually used Charlotte's Web cream, or placebo cream. They measured their pain at day 0, at the baseline, and then 14 days in. And here's what the data looked like. The red squares, these are the CBD arm, and the blue is the placebo arm. And so here you have basically the baseline number for pain is on this axis right here. So this is the baseline, day 0, and then this is day 14, a significant reduction in pain with the CBD cream. Sorry. The placebo is basically no significant difference from day 0 to day 14. So this was a significant difference here. And it basically showed that CBD in a cream form does have significant ability to reduce pain and inflammation. What about safety issues? Well, it turns out that there are some significant safety issues with CBD, particularly at high doses. Epidiolex, which is again used in kids, the dosing is based on weight, but a typical dose is going to be in the range of 600 to 800 milligrams per day. And because there's such a potential for liver toxicity, Epidiolex prescribers are required to monitor liver function studies. There's also data from the Epidiolex FDA submission, which clearly shows that CBD inhibits a specific enzyme in the cytochrome P450 liver system. It's called CYP2C19, and that enzyme is responsible for the breakdown of 10% of the drugs that are in clinical use, including anticoagulants like warfarin and Plavix, the benzos, PPIs, and certain SSRIs, and actually all tricyclic antidepressants, not that they're used that much anymore anyway. And so finally, then there's the issue of quality, and that's really part of the safety issue. A 2017 study in the Journal of the American Medical Association showed 84 CBD products were tested from 31 companies. 69% were incorrectly labeled. They had more than a 10% variance from the label claim, and 21% of them contained significant levels of THC. A study that was released online literally a week ago, came out of the University of Mississippi School of Pharmacy. Same type of study. They took 25 commercially available hemp oil products and analyzed them. 75% of those products were above or below their claimed label of CBD by more than 20%. 12% of the products exceeded the legal limit of THC for CBD products in the United States, which is 0.3%. And 16% of the products actually contain synthetic cannabinoids, which here in the States will be called K2 or spice. So there's a real buyer beware here in terms of the commercial CBD products, at least the ones that are being sold in the United States. So the take-home message on CBD, the legal and regulatory status is still unclear. We've been waiting here in the States for the FDA to basically get off its keister for 2 years now, and still nothing's really happened. But the potential for pain and inflammation benefits at this point is still largely based on animal studies and anecdotal reporting. There is only one human trial that looked at pain, inflammation, or an immunologic endpoint. That was the TMJ trial. There are more that are underway. And finally, lots and lots of patients undergo work-related drug testing. Here in the United States, there's roughly 6 million adults who go through drug testing through the Department of Transportation because they are truck drivers or train engineers, or they work as airplane mechanics, and they cannot have any detectable THC in their system. And so, for patients that undergo work-related drug testing, buyer beware, caveat emptor. Okay, so let's talk now about PEA. PEA is palmitoylethanolamide. And as you'll see in a minute, it has many of the same potential benefits as CBD, but a lot more data to support its efficacy. The history of PEA is really fascinating. It was discovered back in the mid-50s by Merck scientists from the drug company Merck. And it was initially discovered in egg yolk, peanuts, and soy. And it was a fatty acid amide, which they identified as palmitoylethanolamide, which had very distinct immunomodulatory and anti-inflammatory benefits. They also realized that this was a compound, PEA, which was produced naturally, endogenously in human tissues. The interest really was picked up in Europe. And for the next 20 years, a product was produced called Impulsin. And it was sold in Europe, produced in Czechoslovakia. This was felt to be an immune modulator, and Impulsin was sold for the prevention and treatment of viral upper respiratory infections. Through the 1980s, nobody really understood how this thing might work. There was really minimal research being done. And then when the Iron Curtain fell in the late 80s, the company went away and Impulsin disappeared. But a few years later, what happened was CB1 and CB2 were identified in the early 90s. And they realized that the signaling molecules that bound to those cannabinoid receptors were fatty acid amides, like anandamide, AEA. And that really pointed the way towards looking at PEA, which everybody knew. I mean, lots of scientists knew that PEA had some interaction with the immune system that was really interesting. They didn't understand what it was, but now they realized maybe it was working like these other fatty acid amides were in the cannabinoid system. And so it took a few more years, but then in about 2006, the PEA receptors were identified and its mechanism of action were clarified. And then over the past 10 years, there have been multiple European clinical trials with PEA published. So let me just quickly tell you a little bit about the biochemistry of PEA. It's a fatty acid derivative, just like AEA, anandamide, and 2-AG, and it's produced just like AEA and 2-AG in our tissues. Now, AEA and 2-AG are derived from arachidonic acid, which is a 20-carbon unsaturated fatty acid. PEA is derived from palmitic acid, which is a 16-carbon saturated fatty acid. But interestingly, PEA is broken down by FAAH. If you remember back that slide where I circled that in red, FAAH is fatty acid amide hydrolase. That's the same enzyme that breaks down AEA. And we'll see why that's important in a second. But the bottom line is that PEA is unique because it is both an endogenous and exogenous cannabinoid. It's endogenous because we make it in our tissues. It's exogenous because you can extract it from egg yolk and peanuts and soy. And it's now produced as a supplement in Europe, in Canada, in the United States, and it's generally recognized as safe. It's on what we call the GRAS list with the FDA. It's sort of an unfortunate acronym given that it's a cannabinoid, but nevertheless, that's in the United States, we call that the GRAS list. So it is synthesized and released in our tissues on demand, locally in response to injury or inflammation. It serves as a negative feedback signal. So locally, it reduces inflammation and decreases pain. And it reduces the release of cytokines from mast cells, monocytes, macrophages. These are all white blood cells, and reduces the pathologic overactivation of those cells. And these actions occur because PEA activates cannabinoid receptors. So let's see how that happens. This was the diagram for CBD, right? It strongly desensitizes TRPV1. It weakly activates PPAR alpha, and then indirectly CB1 and CB2. Well, what does PEA do? PEA, primary receptor, PPAR alpha. So it downregulates the activity of mast cells and dramatically reduces the release of inflammatory cytokines. It also strongly desensitizes TRPV1. And it does exactly the same thing as CBD in terms of increasing tissue levels of AEA and 2AG, which then gives you indirect stimulation of CB1 and CB2. So the trials, the clinical trials that have been published over the past 10 years include a number of really amazing endpoints for PEA. I'm going to just take you through a handful of these. Sciatica. This study was done in Spain. It was published 10 years ago. They took 600 some odd patients who had pain from sciatic compression, and they randomized them to either placebo, 300 milligrams or 600 milligrams of PEA daily. It was a 3-week study, and they looked at the visual analog scale of pain. That's where they basically give you a scale with a happy face down at 0 and a very sad face at 10, and they say, tell us where you are on this visual scale of pain. So it's typically done on a scale of 0 to 10, and they measured that at baseline, day 0, and also at day 21. And so this is what the change was over those 21 days. This is placebo right here. This would be 300 milligrams, the change, and this was the change between day 0 and day 21 with 600 milligrams of PEA daily. Both the 300 and the 600 milligram groups showed statistically significant changes. This is a probably even more important statistic, though, and it's called the number needed to treat. Now, some of you may be familiar with that, but what it basically is we say, okay, if we're going to treat patients with this intervention, how many patients do we need to treat in order to achieve a specific endpoint? And in this case, the endpoint was a 50% reduction in their sciatic pain. So the question was, how many patients do you need to treat at the 300 milligram dose and the 600 milligram dose to get one patient to have a 50% reduction in pain? So a perfect treatment would be an NNT, a number needed to treat, of 1. That means every patient you treat gets that 50% reduction. So if we look at the 600 milligram dose, that's the yellow here, okay, at 2 weeks in, the number needed to treat was about 3. And by 3 weeks, the number needed to treat was about 1.5, which means roughly 60 to 70% of patients that were treated with 600 milligrams were getting at least a 50% reduction in their pain. And that's pretty significant. Osteoarthritis of the knee. This was actually a study done in Australia, and it was published just last year. They had 110 subjects with osteoarthritis of the knee, again, randomized to placebo, 300 or 600 milligrams of PEA daily, an 8-week study, and they measured pain scores, and this is what it looked like. And so what you see here is the decline in pain scores, the green line with the placebo arm over the course of 8 weeks. And then the blue arm was 300 milligrams of PEA per day, and the red was 600. Statistically significant improvements for both, but better with 600 per day than 300. TMJ pain. Now, we talked about the fact that there was a cream study with TMJ pain and CBD. This is an oral study. 24 patients with TMJ pain randomized to either 300 milligrams twice a day of PEA, a total dose of 600, or ibuprofen, 600 milligrams 3 times a day for 2 weeks. And so over the course of 14 days, again, this scale right here, that's the visual analog scale of pain. The blue is ibuprofen. The gold or yellow is PEA. And what you see here is that over the first couple of days, ibuprofen does a better job. It's pretty quick in terms of giving you some pain relief. PEA starts kind of slowly, but by the time you reach day 5, the curves cross. And so what you're seeing now is that the ibuprofen plateaus and the PEA just continues to give more and more pain relief over the course of 14 days. Depression. Now, this is kind of a surprising study. This was a study where they took 54 subjects who had newly diagnosed depression, and they were all being started on Celexa, which is a serotonin reuptake inhibitor. And they had their depression measured at day 0, and then they were randomized. Half of them took just Celexa. The other half took Celexa plus PEA. And if we look at their depression scores over the course of 6 weeks, what we see is this is the line, the gray line here, for depression declining in the group that just took Celexa. But if you add the PEA to Celexa, these patients get better quicker and more completely. And you might say, well, what does that depression have to do with an anti-inflammatory? And the answer is that there's a ton of new evidence over the past several years that patients who are severely depressed have inflammatory changes in their brain. And so adding PEA to an SSRI makes that SSRI more effective. The final thing I want to talk about is viral upper respiratory infections. And these were trials that were done back in Europe in the 1970s with that drug that I mentioned, Impulsin. And so there were 5 randomized trials. They were placebo-controlled. They enrolled a total of 3,600 subjects. The first trial was with factory workers. The other trials were with military recruits. The dosing ranged from anywhere from 600 to 1,800 milligrams of PEA per day. Here's the first study. They randomized 468 factory workers to either PEA or placebo, but for only 12 days at the beginning of cold and flu season, meaning during the winter. And they then followed these factory workers for 8 weeks. Any subject in the study who had upper respiratory infection symptoms was then seen by the company physician. Compared to the placebo group, the PEA group had a 46% reduction in fever, myalgias, which is muscle soreness, and sore throat symptoms, statistically significant, a 30% reduction in the total number of subjects that had upper respiratory infections in the PEA group, and a 21% reduction in the average length of illness. So then, this is, by the way, a graph which basically shows the dark line here is the PEA group showing total disability during the course of 8 weeks, and this is the placebo group. The second study then looked at 900 military recruits, and they randomized them again to either PEA or placebo, but for an entire 8 weeks. And what they discovered was that compared to placebo, the PEA group had a 37% reduction in the total number of upper respiratory infections, highly significant, and a 40% reduction in the total days of illness, but no significant changes in the severity of symptoms. Same graph, second study. Finally, over the next 3 winters during cold and flu season, other investigators did 3 additional randomized trials with a total of about 1,900 soldiers. And they discovered that the incidence of upper respiratory infections decreased anywhere from 34 to 59% by different studies, all of which were statistically significant. So what do we know now about PEA that might explain this? Well, it's a little confusing, to be honest, because we know that PEA modulates the innate immune response by its effect on mast cells and reduces the release of these pro-inflammatory cytokines. And what are these cytokines? Interleukins and chemokines and certain enzymes like histamine, tryptase, and cyclooxygenase. But the point is that by lowering the effect of inflammation, this would explain a reduction in symptom severity. But how do we explain the lower incidence that these studies showed? Well, we're left only with conjecture. Could the reduction in incidence simply mean that some of the subjects in those studies actually did have infections, but just that their symptoms were extremely mild? Well, it turns out in the last 3 studies that I mentioned, they actually did antibody testing. And what they discovered was that in all 3 studies with soldiers, the PEA group had a statistically significant reduction in antibodies to influenza A or B compared to the placebo group. So this is still confusing, though, because basically what it looks like is that PEA supplementation back in these studies in the 1970s appeared to either block infection or it reduced the infection severity enough to prevent a strong antibody response from the adaptive immune system. So at this point, I've shown you these 5 different endpoints, but Again, there are others: endometriosis, carpal tunnel, irritable bowel, fibromyalgia, and there's even more. The bottom line is this is a compound that has really broad applicability. And before I get to the last few slides, I want to just introduce this woman who is a Scottish lady. When I do this talk in person, I typically ask the audience if anybody knows who she is, if anybody recognizes her picture. Her name is Jo Cameron, and about a year ago, she was kind of in the media quite a bit. The BBC called her the woman who doesn't feel pain. And it turns out that if we go back to that slide where we talked about FAAH, right? Fatty acid amide hydrolase, that's the enzyme that breaks down AEA and other fatty acid amides. And it turns out that Jo Cameron, who's 72 years old, has had a lifelong history of pain insensitivity. She would cut herself and couldn't feel it. She would burn herself and said the only reason she knew she had burned herself is she could smell the burning. She had surgeries with minimal discomfort afterwards. She had hip replacement that required no post-operative analgesia. She had childbirth with no pain. And they basically said, how is this happening? She's also never experienced any anxiety or depression. And so they did genomic testing on her. They basically sequenced her genome. And what they realized was that she has a microdeletion in the gene that codes for FAAH, the enzyme that breaks down AEA, anandamide, and PEA, and another ethanolamide called oleoyl ethanolamide, all of which do the same thing. And if we look at blood levels in this woman, which are in red, and these are 4 comparative controls, what we see is that her levels of AEA, PEA, and OEA are basically 3 or 4 times higher than controls. And somehow this endocannabinoid system's overstimulation, because the enzyme doesn't break these compounds down, essentially gives this woman congenital insensitivity to pain. So let me now quickly just tell you about our product, which is called Cannabrex. It's a dietary supplement. And essentially each capsule is 300 milligrams of micronized and solubilized PEA. This is solubilized because PEA is not easy to absorb. And so this process of micronization and solubilization basically almost doubles the absorption compared to standard PEA. This is the pharmacokinetic testing that was done with this product. Essentially, the blue line is Cannabrex. The red is just micronized PEA, and the area under the curve is about 80% higher over the first 4 hours with Cannabrex. It is not derived from cannabis, so there's no possibility of THC content. The suggested dose is 1 capsule twice a day, and we encourage providers to essentially double that dose in the first week of treatment. This product is produced in an NSF certified facility. Now, what is NSF? This is a nonprofit organization based here in the States, which does third-party conformity assessment services, and they essentially certify facilities that make dietary supplements as being GMP compliant. GMP stands for Good Manufacturing Practices. And so this is an independent, nonprofit, third party, which essentially certifies the manufacturing facility. The product goes through third-party content testing to certify purity and content accuracy. How do you use this with patients? They've got to understand that this is not a rapid onset analgesic. This isn't like taking ibuprofen, which might work within a few hours. Depending on the condition treated, significant clinical improvement could take anywhere from 2 weeks to 2 months. So start patients on a loading dose. The first week, double up, get the tissue levels up quickly. Take 2 capsules twice a day. And then after 1 week, you can downshift to 2 pills a day. You can either do that 1 in the morning, 1 in the evening, or plenty of providers just have them take 2 capsules once a day after that first week. It's extremely well tolerated. The side effects are extremely rare. Occasionally, patients will say they get a little bit of GI upset, like any supplement. If you take it on an empty stomach, that can happen. You've got to counsel patients about what to expect. Make sure that you've set their expectations reasonably. And finally, because this is a question that gets asked a lot, it can be used synergistically with medical cannabis or CBD, and it may actually enhance their efficacy through an entourage effect. So what are the key clinical takeaways? Cannabrex and PEA is the only endogenous and exogenous cannabinoid ligand. It's not derived from cannabis. There's no THC or CBD content. It's broken down in peripheral tissues and not the liver, so there are no drug interactions or contraindications. Side effects are rare. There's no known toxicity in all of the clinical trials, and there's really now 24 clinical trials that have been done in Europe. Multiple clinical trials have been done which show benefits in chronic inflammation and neuropathic pain, and it appears to potentially reduce the incidence and severity of viral upper respiratory infections. So, can Cannabrex actually play a role potentially in the prevention or treatment of COVID-19? Well, the science is strong enough that last week a United States pharmaceutical company filed an investigational new drug application with the FDA, and they are now starting phase 2 testing of PEA in a clinical trial in COVID patients. They're going to try and get an indication for PEA to be a prescription product in the United States, as well as a supplement. So while the jury may be out regarding PEA and COVID, there is actually still plenty of other evidence about other micronutrients. And so I'd like to invite everybody to join us next week on Tuesday, because we're going to be doing a webinar about other micronutrients and viral infection and how we can potentially develop a rational approach to this novel coronavirus. We'll cover the latest findings on vitamin D, on zinc, and a number of other supplements. And that's really it. I want to thank everybody for joining us today.
All right. Thank you again very much, Mark, for this. Thanks for going through the PubMed and sharing the research. I'm looking forward to your micronutrients for viral infection, separating fact from fiction during COVID-19. And again, I want to thank Ian and the whole group from Theralogix for sponsoring today's educational webinar. That was wonderful. And thank for you guys for coming in with your great questions and joining us in our community educational moments. So thank you very much. Do visit healthyseminars.com/Theralogix to watch this replay, to sign up for the next webinar, and also to be able to get more information from Theralogix, including the handouts from today's lecture and any specials. And then continue to visit our resources page, because you'll see that we keep adding more and more. And I'm already in talks with Mark for a third one. So there's one on June 16th, but we're already talking about something probably July or August, another talk, because he likes to look at the research and I like to have somebody tell me what it says in an hour. So we're going to do this again. Thank you guys. And thank you, Mark.
Okay.
Appreciate it.